All right, I hope everyone made it back from our stretch break and is ready for our next presentation. Our next presentation, we are joined by Patricia Casey. Patricia has been in the EMS field for 26 years and has held multiple roles in leadership and education. She designed the STARS program for the county she worked in, which quickly gained traction and was adopted by the Cardinal Glennon Children's Hospital. In addition to managing the STARS program, she works as a pediatric home health nurse. Patricia's presentation, the STARS program, improving pediatric emergency care for pediatric patients with medical complexities, will cover the following objectives. Review the development and key highlights of the Special Needs Tracking and Awareness Response System, STARS. Discuss the data components and educational trainings which are integrated into the STARS program. Review 2 brief patient scenarios that outline the patient diagnosis and demonstrates how the system works in an emergency situation. And just as a reminder, we encourage our participants to use the Q&A box to ask questions to Patricia that we'll address after the presentation. All right, I will turn it over to you, Patricia.
Okay, hoping everybody can see my screen now.
It looks great.
Great. Thank you so much for the introduction. And yes, we're going to attempt to run through the how, what, why of STARS. And in addition to that, a few some case reviews. So I'm going to try to get this all wrapped up within the time allotted, allow time for questions. And my goal is always not to put anyone to sleep. I really don't have any disclosures. STARS definitely is not a moneymaker. And also, I will mention that there are all the photos of children that are used in my presentation are those of our actual STARS, and they are being used with written permission from their parents and guardians, and they're also being used with a lot of encouragement. So thank you for joining. And yes, we're going to run through the Special Needs Tracking and Awareness Response System that was born right here in St. Louis, Missouri. So I'm going to start with what is STARS, because it's funny. I actually did a presentation for some of our primary care providers a couple weeks ago, and they said, wait, hold on a second, what is STARS? I was like, wow, that's pretty important. Let me back up a little bit. So what we are in a nutshell, which is, it's very difficult to put us in a nutshell, is we're a comprehensive hospital-based system that we're created to, our main overarching goal is to improve emergency care for children with medical complexities. How we intend to do that and effectively do that is to prepare the local emergency providers, and that's not just EMS. We also include flight systems and community hospitals to prepare them for the children who are in their area prior to that emergency taking place. We truly believe in that proactive rather than reactive approach. And there's a lot of information on these slides. I've been told you will have access to them. I don't want to read through the slides to all of you. You know, a lot of people ask, you know, how did STARS start? I've actually read published material, you know, that tell these great stories of, you know, it all started with one call and one patient. And I'm like, that's exciting. That sounds great, but that's not really true. It was multiple patients who inspired me to create STARS. But quite honestly, to set the record straight, I was at Rock Township Ambulance District in northern Jefferson County, Missouri, right outside of St. Louis. And I was a lieutenant at the time, and I was preparing to create a new hire test, and I thought I wanted to change it up a bit. So I would go ahead and read through our protocols, because, you know, who actually reads the protocols cover to cover, but a nerd like me. And I stumbled across this, you know, this statement for considerations for children with special healthcare needs. And I thought, wow, sounds great. We don't do that. So maybe we should. I did a little bit of Googling that night in my office. All I think I put in was special needs / EMS, and I found the EIF form. For those of you who aren't familiar, that's the Emergency Information Form that was created in 1999 by the American College of Emergency Physicians and the American Academy of Pediatrics. It's a great form. It had fantastic information on it, but I knew we needed more. We needed that pre-planning. That was going to be imperative. I saw very little value as an experienced paramedic in arriving to a patient's home in a high acuity situation and being expected to pause and read information that was mostly, typically handwritten, and about syndromes and equipment that I potentially have never heard of before or laid eyes on before. We had to have that training. The emergency management plans, as far as the treatment, guidelines went, or as on the EIF, I think it says known effective treatments, they needed to be geared towards the scope of EMS. They weren't always that way. So it was really important that what we were going to suggest on these forms we needed to take scope of practice into consideration. Again, these slides will be shared so you know all of this, because I wanted everyone to have access to these plans in the ambulance. I needed to connect them with 911, needed the support of our medical director and the support of a pediatric hospital. Operation Rock Stars at Rock Township was formally accepted by the board of directors in 2014, and it operated out of the EMS agency for almost a year until I finally got that true pediatric support from Cardinal Glennon Children's Hospital and Dr. Stephen Laffey, our medical director, who I cannot not name because he has definitely been our champion. So how STARS operates today is out of a centralized database, and that was it had to happen. We learned quickly that working off of paper plans was not going to work. They became too easily outdated, too easily misplaced. There was a lot of question regarding HIPAA on how and where they could be stored. So we're like, you know what, we need eyes on, we need clinical oversight, and we need these in one location for everyone to access, and again, version control. So everybody who was accessing that plan in emergency was looking at the same plan. Our plans are, what you see up here on the top picture would be a view of the STARS database. If you would log in and see all the STARS by number, what we call their badges. And that would, if you were logging on as a paramedic at a ambulance district or, a charge nurse at a hospital, you would default to the STARS in your area, and then you can search all. I have a screenshot of my administrative screen, so I see everything. But any STAR can be searched by their number or name, no matter what location they're in. We did learn that asking EMS to log in with a password was not going to be effective. It wasn't going to work. That was a no-go. While they were trying to, map their way to a call, these passwords, they had to meet the standards of our hospital system. So they expired every 90 days. I actually kind of knew that was going to be a fail, but it had to be a proven fail before my hospital would accept that. So we did develop in our version 2.0 a way to send text links to emergency plans for these children. So if a parent, how this works is a parent calls into 911 and says, they can identify themselves as the guardian of a STARS patient, or that they're calling for a STARS patient. Most of our dispatch agencies have the children flagged in the home. So if the call does originate from the home, they'll usually ask, is this for the STARS patient? But they can look up the STARS child and they can actually dispatch that plan to whatever ambulance service is responding, and send a protected text link to the cell phones of the ambulance. They can click on that link, which will open the STARS plan and give them 2-hour access to it. That plan only, not the rest of the database. So here's just a quick view of the framework of the STARS program, an overview of the STARS program. FSM Health Cardinal Glennon remains the main hub. We are the home of STARS. We currently have St. Louis Children's as a pediatric-based hospital and Golisano Children's in Fort Myers, Florida as another pediatric-based hospital. But how we are designed is that pediatric hospitals are the ones driving the plans for their children as they are discharged and identified as being at high risk. And from there, we also have the involvement of EMS medical directors, which is something else that we added that is unique to our program in comparison to others. And I'll explain how that works in the next couple of slides. But those who have viewer access are what you see on this bottom tier here. We have the 911 dispatch centers, community hospitals, ground and air EMS. I should add, fire departments, any first responder, and our interfacility transport teams, our specialty transport teams have access to that as well. So here's an example of a STARS plan. This is a child that has an out-of-hospital DNR. And this is how the STARS framework for enrolling a child works. So referrals come to us via multiple different areas, and we have multiple subspecialties that are very bought into STARS. I often get asked, where do your referrals come from? I'm like, everywhere. My biggest ones are going to be the NICU, cardiology, our complex medical care department, and our palliative department. But it comes in, the STARS team drafts this, which is myself and my partner who also has EMS background. And that's so important because we do have a very good understanding of the capabilities and limitations of the EMS providers in the area that the child's going to, and that of the community hospital, which varies so greatly, as most of you know. St. Louis is interesting because we have, we span throughout Missouri and Illinois for STARS. So we enroll children who are in extremely busy urban areas with 2 tertiary hospitals on top of them, all the way to extreme rural who are going to be at least an hour away from a community access hospital. So those change up depending on where they're going. So after we would write that plan, that goes to our hospital medical director for formal approval. And what you can see in this lower box is the dual approval system that we have set up. So the pediatric hospital medical director reviews that, hits approve within the system, which automatically sends that to the EMS medical director. And that can be set up as a state, regional, or local medical director, whoever it needs to be for that ambulance service. That's dictated by where we have signed the plan to. They read the plan and they hit approve, or they can defer. We rarely get deferrals, but the purpose of that is to spare time when paramedics may be wondering if this truly, is in their standing orders. Am I able to do this, or do I need to call for orders for this certain treatment? And this allows them to know, no, my medical director has already said, I've reviewed this, I approve any treatment or order instruction that is on this plan. So not until that secondary medical director hits approve does that plan go live and become accessible for viewer level providers to look at. And then we do training as needed as we get newer kids coming out. Why is obvious for a lot of people. When you're talking about children with medical complexities in the emergency services world, there's a lot of clashing going on there. Emergency medicine for pediatric patients especially tends to be very algorithm based. We're used to following recipes, and honestly, that's a very safe and effective way to treat patients when time is of the essence and there's little time to look up what's the right thing to do for this kid. Unfortunately, a lot of our patients don't follow those algorithms well, and some of them, while they might not benefit from them, they could even potentially be harmed from following these protocols. So we know that that's why programs like STARS are needed. Looking up their information in an EMR system, it's really, really complex, especially as fragile and as complex as our kids get. There's no way to get that synopsis within Epic or other systems. and using care everywhere, you just don't get the information that you need for an emergency. We know that we've seen these significant clinical errors, and even death has occurred. And most of all, of course, they matter. So there are traditional paper forms out there, and yes, I have bias towards stars. I've been doing nothing but stars for 8 years. But what we've come up with when people ask, why can't we just do this on paper? What I'll say is we've tried it and it's failed. Paper has holes, paper doesn't hold weight. And you can see all the reasons I have up here for patient has holes, but when I have paper has holes, but the paper holds no weight. Really, to me, what I'm talking about is the fact that when you just throw paper out there, you don't have that assurance by EMS that their medical director is okay with this. And there really typically isn't a whole lot of education that goes along prior to those going out there. And also, as far as HIPAA goes, we track on the back end who accesses these plans. It's something that security has, demanded and expects, but we actually encourage EMS providers and community hospitals to review the children in their area outside of a patient encounter. That's what it's for. Parents know that signing in, it's an opt-in program, and we really do want them to be as familiar as possible with these plans prior to these emergencies taking place. I went over the why, the formal why, but the real why is our patients. They mean everything to us, and they are our main stakeholders. In fact, I was asked not long ago for a publication that our partnering university wanted to write was, can you please name your stakeholders when you built this program? Like, well, it's the patients, quite honestly. We were doing it all for them. So when you talk about assessment challenges in this population, they're huge. This topic is so broad that this would be a lecture in itself. But what I like to say is if you've met one, you've met one. If you don't know what's normal, it is impossible to assess for the abnormal. Without having a good baseline to start from, your assessment really doesn't have much value. And this is just a short list of findings that could be either a baseline finding or a critical finding in many of our kids. And actually, I just added hypocarbia recently because I reviewed a call from one of our chronic hypoventilation children who, when EMS called in, they reported an end tidal of 17, and she's on a ventilator. And I almost fell out of my chair that the nurse didn't ask to do a pulse check and for them to do a pulse check immediately. But after talking, pulmonary and reviewing the emergency room, and I knew it was her norm, but it shouldn't really be a norm for anybody. She's one of those extreme outliers, but it is normal for her, and we'd much rather her be there than hypercarbic. So what pulmonary said was, let me manage that when she gets here, let her sit that low. It's okay. And so it's an example of you just really have to know what is normal for these kids. I wanted to show some example plans of some of our extremes. Alec I always have to use his plan because his mom appreciates it, that he still lives on in teaching others. So Alec was my first LVAD patient that I ever enrolled in STARS. He's no longer with us. He passed away a little over 2 years ago. He was an osteosarcoma patient who survived his first round of chemo, but he survived, his heart did not. So he was not a candidate for heart transplant unless he would make it 2 years being cancer-free, which he did not ever meet that stretch of time. So his VAD was a destination device. But I learned so much from him. And this is the first patient that I started following when he traveled. So, the issues with Alec is he was extremely active and he wanted to live life to the fullest towards the end of life. And so they traveled coast to coast. He went to Disney World, he went to every beach, and he looked like a typical kid. Now, this photo of him has been photoshopped, but this is actually him in his Halloween costume, I think in 2017. But the straps you see on his costume, they airbrushed it out, but that went to the backpack that he held, that his VAD stayed in. So he just looked like a typical kid jamming around with a backpack on, and you wouldn't know that or suspect that this kid had a VAD. Every time I called a hospital, I braced myself for him to tell them that this child was coming to their area. I braced myself to be, for them to kind of treat me like I was doing a little bit of overkill here. But honestly, that never happened. Everybody was extremely appreciative of having the information. And his very last trip was to Washington, D.C. And when I called Children's National, they put me in direct contact with their cardiothoracic surgeon. So they did take it very seriously, as well as the extremely busy fire department of Washington, D.C., who also called me to confirm that he was home safely after the trip was over. This is another one I wanted to use as an example of just to show how important these plans are. This is my friend Nathaniel, and he was the 10th star I ever enrolled in the program back when STARS was at Rock Township and just an ambulance-based program. But I was really shocked. I'd never met a kid like Nathaniel before. He's had a complete laryngotracheal separation. So we had added a photo of his airway. So that people know that there is no way to ventilate this child from the nose and mouth, and there is no way to visualize that from the outside. And he is another one that we make sure that we follow around when he travels, that his STARS plan is always accessible and on him in some visible way in case something were to happen to his parents. One of the reasons why we focus on tracheostomies so much, and I had to add this slide just because it is so important to us, is because this is where we've actually seen that neurological devastation and death. So if any of you on this call have any question at all regarding your protocols for emergency trach changes and pediatric trach care, please, clarify it if you can. I was able to contribute to the 2022 NASEMSO guidelines, and it does have an updated pediatric tracheostomy protocol in it that can be used. But, this is what you see right here. This was I did my own little study from 2010 to 2018 from our tracheostomy list and came up with 6 severe neurological injuries and 5 deaths, which is, if you ask me, extremely significant when you look at the fact that each and every one of them was definitely easily correctable. Education is a huge part of our program. The emergency plan themselves are only one part. We met them where they were at. So for example, St. Louis City, here's a picture down here of them in the ambulance. There's no way to pull them. Their volume is too high. Their resources are too low. You cannot pull them into a classroom setting. So we rode with all shifts with a duty officer, made sure we hit them all for training on the fly. When we had a new high acuity patient going to their area who is extreme high risk because of her airway and her ventilatory needs. And that picture there is at Barnes, our main level 1 adult trauma center. And we found if we sat there for long enough, we could hit most of the crews. And here I have 3 crews together in the back of the truck reviewing one little girl's STARS plan and running through emergency trach changes and how to properly bag her if she were to get into trouble. I wanted to talk a little bit about what we do beyond STARS, which is our data tracking, mapping, and then we've recently been more and more involved in is disaster planning, which is something that I didn't really see when I first designed STARS. But of course, as STARS became more and more popular, everyone wanted to know results and they wanted metrics. I have a 1 kid counts motto and I have lots of anecdotal stories, but when you start getting into medicine and cost and everything else, everyone's like, okay, cute stories, Trish, we want numbers. So we now do very closely track system use, system enrollment, our demographics, everything you see here. This is a heat map that we can pull that's actually grown since I took this screenshot, but of our area throughout Missouri and Illinois. And what you see in the red is our what we consider our high risk zones and our volume of patients there. And those have been pulled by CDC data that includes infant mortality rates and those living below the poverty level. So we also, with this, really, I'm very interested in population health, looking at the growth trends of this population, since we know they are the fastest subset of pediatric patients that exist, or these ones with complex needs. And then I really have a big interest in looking at these unexpected out of hospital deaths and where they're occurring, and if they're occurring in with more frequency in areas that we already know are high risk. Again, you can see we look at our emergency activation use. We can pull that down by user, by district, and then looking at our enrollments and how many have deceased, how many are active, how many are in draft form. I left the names here because these are actually all providers within our hospital and St. Louis Children's Hospital, but these are dispatchers. And as you can see, we also expect our charge nurses in our emergency rooms to be opening these plans when EMS is calling in, so they can be referencing the same plan. So something that, again, I mentioned I didn't really expect was the role we could play in disaster planning. So we can map these children out now accurately where they are, but not only that, we can map we can pull out those who are technology dependent. And my medical director and partner spent a really long time creating criticality levels. So patients who, for example, who are dependent on electricity for their airway, for a vent, for suction, for oxygen, those are a level 4, highest level criticality. And they've also factored in the ability to how easy it is to move them as well when you're talking about disaster, those who are not ambulatory and require mobility devices. So what you see here is I pulled Central Missouri down to critical cases. I can drill down on these and pull patient names, which is what I did in a screenshot over here, and then look at the devices they had. And that can be also sent on a map to a fire department, so they know where these kids are located. And what was very interesting and eye-opening for us was after we joined forces with Golisano Children's, which is right there in Fort Myers, that got hit the hardest by Hurricane Ian. We wanted to help. We wanted to do anything we could do to help. Like, what can we do for you? They were not expecting to have to evacuate their NICU, which they did. They were not expecting to have to evacuate any part of their hospital. So they were in a mess. Their STARS coordinator said, is there any way you can check on our children who are, both in draft form and those that are live? And we said, absolutely, give us a day. It took less than a day. We joined forces. We pulled a spreadsheet out from there. We chose Florida, looked at their criticality levels, and we just started doing phone calls. What was interesting is that we were able to identify some areas where we could help. One of these kids had located, surprisingly, only 20 minutes from Cardinal Glennon in Illinois, and they were out of her ketogenic diet tube feeding formula. One of our dietitians here in our complex medical care clinic secured it for them and got it for them right away. I was able to tell them, you have a grandma at this shelter who's out of these supplies, et cetera. And they're like, okay, we got it. We're going to get them to her. So that was just really phenomenal to see what we could do through this, what we see as a simple program from multiple states away. So here's just some STARS photos in action. Everything we do. Here's some hands-on training. We love to get our patients, and their local paramedics together so they can learn, so they can truly experience that baseline, get hands-on equipment. This little girl is extremely difficult to move just from her wheelchair to a stretcher. So let's practice moving her. and she loved it actually. And it really taught the paramedics a lot. And what's interesting is when I developed STARS, my intent was to take fear away from the children. I wanted no child to be afraid of who are supposed to be their helpers in a scary situation. And what I learned quickly, and which still holds true after 8 years, is it's the opposite. The kids aren't afraid of the paramedics. They love them. They get excited about it. It's the paramedics who are a little bit hesitant to put their hands on the kids and how to communicate with them. And they're just a little bit nervous until they really get to know them and learn that, okay, you know, this is just any other kid. They just have some different equipment and they communicate in different ways. And I won't break them if I touch them, with the exception of a few. And we point out those that they can break. So, you know, it was really neat to watch that transition. This is a picture I took of our fall first day of school rush. We always do a who's going to school for the first time, who's going, you know, let's get all of your folders ready for your school nurses and make sure you have your tags on your backpack, et cetera. So that's always, you know, we call that, that's a busy 3 weeks prior to school starting in our office. Over here on the far right, what you see is a call that actually occurred last week. And I was excited when I saw that the parent had posted a photo of a paramedic looking at his phone. And when I zoomed in on it, I could see that he had actually pulled up the STARS database on his phone. So he had clicked on that text link from dispatch and was reviewing the STARS information while assessing this child. And here's a picture of just advocacy. We do a lot of speaking. I started speaking to our residents before they head out there about caregiver interactions and what our program is. We have many, I'm going to trying to be respectful of time here. So I'm going to rush through these last ones, but we have many goals. Our overarching goal, as I mentioned before, was to, you know, improve safety and efficacy of care for this population. But we also want 911 to be a safe and trusted option for all children. We still have areas that we're working on that parents will not call 911 because they would rather take the risk of putting their child in a car and driving fast. They want to make it to their tertiary center. They know that the local areas don't manage their children well, and they don't trust them. We want to eliminate those sentinel and never events, which we've done a pretty good job doing. And to reflect back on some of what Dr. Ferris talked about with transport decision making, when you're looking at time critical diagnosis, while that is usually limited to stroke, STEMI, and trauma, you know, our kids count in there too, because we need to get them to definitive care, and time does matter. So when we can get them safely and train EMS to support them and be comfortable with their equipment, we try to get them from seeing directly to tertiary hospital, which we are able to do 90% of the time. We also want their community ED to be a safe and prepared option if need be, and then remain home if they can. So just some examples of that. Here's that considering 911 a safe option. This was very early, one of the first moms I called in St. Louis City to get her enrolled in STARS. And she was like, you know, no thanks. Not really interested. I just called private because they don't have the equipment we need. They said they don't do trachs. I've never used them since. That was when her little girl was a baby. And I said, can you just give us a chance? I'm working with St. Louis City right now quite a bit. We're doing a ton of training. Just give them a chance. And sure enough, she did. And this was one of their most recent, well, in 2017, but the next call she used, and you know, you can see they did a very fine job. They had her on end tidal within her vent tubing as we asked. They did a fantastic job, identified her STARS plan, took her to us, and now mom uses them with consistency. Here's an example of remain home at safe, and remember, you will get copies of these, so you'll be able to read what is within the run report here. But this is an example of EMS replacing a G-tube. Replacing a G-tube can be done safely in the home with the proper training. And we have trained the majority of our providers in our area how to do that. And this is them doing just that. And they did it very well. They did it safely, and they talked to their medical direction. So when we do have these treat no transports, we do track them very carefully to make sure that they are being done safely. Here's an example of a scene to tertiary where STARS was used in a transport. So I was very impressed with the radio report. The paramedic called in, included the STARS number, an accurate description of the patient's status, including all of those deviations from his baseline state. And, you know, he even said he was administering measured fluids for hypotension, but monitoring closely because he had noted on the STARS plan, this kid is also at risk for hyponatremia. When we pulled up the date of the call and looked at who accessed, we see Union Ambulance District accessing this plan twice, and we see Dr. Stephen Laffey, our medical director, who was the attending in the emergency room, who accessed that plan as they called in their report. Here is that little boy's plan with his anticipated emergencies and his caution notes. So they, the scenario was this child decompensated after coming home from his PCP's office very rapidly. And they ended up transporting him from Union, which is about an hour away from here. The closest hospital is probably 15 minutes from them, but has not managed him well in the past. And admittedly, they don't want him there. They don't have the tools to manage him appropriately. Plus, something else that we track is average time at outside hospitals, and it's 3.6 hours. So we know it's going to take a while to get someone there for interfacility transport. But they treated everything as noted in the plan. They gave his steroid for his adrenal insufficiency. They monitored his temperature very closely, and with the warming efforts documented, had continuous ETCO2 on him, and even swiped his vagus nerve stimulator magnet twice. Everything that we had written in that plan was done to a T. Again, you'll have these so you can read through the outcomes in that as well, because I do see I'm running short on time. This is something else I wanted to highlight, which is a pre-STARS call, you know, because we have made a difference, and I'd like to show that. So this is unfortunately a child who was doing very well. He had lost his twin sister in the NICU. He made it. He got home. He just needed time on event for his lungs to grow and become stronger. And mom called for EMS after she had suctioned twice. He desatted twice, and she's like, you know, I'm not comfortable with this. I'm going to call 911. As soon as they started taking him out to the ambulance, she said, you know what, I remember what I need to do. I need to change that trach. And EMS, unknowingly, because they hadn't had any training, said, no, there's no time for that. He's crashing. They started a code, took him to the closest hospital where he arrived. These are notes from the closest hospital, where he arrived with his trach in place and no air movement. The attending physician did a trach change immediately, got return of ROSC after one epi. But unfortunately, you can see his post arrest status, which is very severe neurological devastation. And this is how his state still is today. There has been no improvement in this at all. What you can read over here is his pulmonary visit 5 days prior to the incident occurring. Here's a post-STARS call. So 4917, one of our North County agencies, dispatched to a 1-year-old male on the floor. Mom states patient's trach was dislodged and she's unable to get it back in. He was very cyanotic. What had occurred is we had just upsized him here at Glennon, and mom had done a routine trach change and then noticed that he had decompensated rapidly. And what had happened was that had become decannulated with the ties in place, which is something that we teach them. So EMS immediately assessed under the drain sponges and saw that that trach was coiled up in his neck and not in the stoma. They attempted to reinsert that 4.0. Mom, fantastic, but had just, you know, she really didn't have it together because her kid was crashing in front of her and she was alone. The paramedic asked her, reminded her, where's your smaller size? He knew from training that there should be a smaller size there, and by the STARS plan that there should be a smaller size. So she grabbed it for him. He reinserted it. Child did really well. They transported because they felt that they were in fear that he had aspirated, and it was appropriate to get him assessed. So we discharged him 4 hours later and sent him back home. So this is a picture of him a week after the incident. I decided to do my own little photo shoot with him. Here are the heroes. Here's him visiting with his local fire department. And here is Sean today. So he is decannulated. He is neurotypical, and he is doing fantastic. In fact, we have graduated him from STARS. He is no longer in our program. He is an official STARS graduate. So, you know, define success, how we've been successful. We've made steps, but we know there's a whole lot of work to do. So again, you'll have access to this so you can read through my thoughts here afterwards, because I do want to allow time for questions. So I mean, I know that was a lot of information crammed into 1 hour. So please, if you have any questions, I'm open to them.
Thank you so much for your fantastic presentation. I'm going to kick it off with a few questions, and then Brittany is going to help me moderate the rest. So you actually have a few coming at you. So first of all, I do want to extend a lot of thank yous. There's been a lot of appreciation from many of the providers on this call. I wanted to extend that to you so you knew that you had a phenomenal presentation. You've reached a lot of people today. So thank you so much for that. One of the common threads that we're seeing with questions is providers from many different states, and they are chiming in with interest to participate in a program. So the EMSC managers are each going to take just a very brief second to let providers on this call know what's happening in our states and who to contact if you are interested, because the answer is going to be variable. So I am going to start with Illinois, so that those providers in Illinois can hear directly from their manager what they should do if they're interested in this program.
Hi, everyone. Glennon Lyons. I'm the EMSC manager for Illinois. I had actually asked Patricia to do this presentation today because I'm well aware of the work that she has done, and because our state, the southwestern portion of our state, borders on Missouri, there's Illinois children that actually are participating in this program and that have benefited from the great work that has been developed through the STARS program. So we're really super impressed by all that's been done and how the program has grown over the years. It's not a program that has extended elsewhere within our state. Typically, pediatric tertiary care centers have information on these patients because they manage them. It's a matter then of being able to access that information, and typically because of HIPAA, it's usually available then to the emergency department personnel, but there are mechanisms for being able to share that with pre-hospital personnel who may need to respond to managing these patients. But this is something that we've gotten questions on about having this kind of a program elsewhere. And so it's certainly something that we can look into further and have some further discussion on. And if you have any questions at all, you can certainly feel free to contact me. My phone number and email address are on the slides that you saw earlier, but I'm happy to just repeat them. Phone number is 312-793-1234, and my email address is evelyn.lyons@illinois.gov. Thank you.
Thank you so much, Evelyn. I'm going to turn it over to Wisconsin next, please.
Hi, everyone. I can take this for Wisconsin. So we currently are doing a program called Children with Special Healthcare Needs Preparedness for Emergencies, or CAPE. It is following currently right now the paper form for the most part, although some agencies are choosing to take the virtual option or take the electronic option. So it is where we coordinate between the schools and then the responding local community EMS agency. Parents voluntarily would fill out a form with the different subject areas. So allergies, diagnoses, medications, words or phrases to use, words or phrases to avoid, any other information. They can attach additional documentation to that form, such as if there's a pretty complex medication list they'd want EMS to know about, or a DNR or anything like that. A copy is kept at the school, and then it is shared with the local EMS agency, that they can use and consult when responding to those kiddos. So we have a lot of rural agencies doing that right now, but anybody can be part of it. We do have a couple more agencies that are in more urban areas that have elected to take those forms, then scan them into their systems. They can just pull them up on their tablets when they're responding. But I would say definitely STARS is the gold standard, and something that here in Wisconsin, we have a goal of working towards. And my info was also on one of the earlier slides, but I can drop that in the chat. So if you're in Wisconsin and want more information or want to get involved, please don't hesitate to reach out. Thank you.
Thank you so much. Yeah, everyone, we will make sure to keep our contact information on a slide so you have time to take a picture, screenshot, jot it down. I can't stress strongly enough, even if there's not something specifically robustly happening in your state, because there are people outside of the Midwest on this call, please get in touch with your EMS for Children team, because this is something that all of us, even at the national level, are working on very robustly. So to answer questions for Michigan, we are prioritizing preparedness for children and youth with special health care needs in our own initiatives. And we have 2 family representatives that advise our committee. And we always encourage our pediatric champions, if you are interested in this, please email me. That contact information will come up, and we have lots of work groups that we can help put you on. And we are actually trying to see if we can use the STARS program as a gold standard, just like Brittany was talking about. It's actually something we've begun to explore. So there is work underway here in Michigan as well for you to get involved if you would desire. Minnesota, do you have anything to add? I see that you have written in the chat, but if you want to add anything verbally, go ahead.
I was just going to say that we don't have this amazing program in Minnesota, but we would absolutely love to get something started. So if anybody in Minnesota is interested, just shoot me an email or give me a call, and be happy to start a work group on this. So
thank you
we'd
so
love
much,
to get
Chelsea.
it started.
Thank you. And then Indiana.
Hello, everyone. Margot Knefelkamp from Indiana. This is something that we're working on. Dr. Greg Ferris, who is our EMS advisor for the EMSC program, is looking into this, and we're working alongside with our state EMS division and Department of Homeland Security. But if you want to get involved, or if you have any additional questions and just want to reach out to me, and we can further discuss. Thank you.
Awesome. Thank you. So as you all can hear, us EMS for Children coordinators really do work hard together. That's why this symposium's even happening, is because we realize that more can be done together than we can individually. So please, please, please reach out to us. We will get you connected and make sure this great work can go to more places. Brittany, if you want to take it away and field the questions for Patricia, I will go on mute and document those answers.
Great, thank you. Patricia, the first one is pediatric emergencies can be stressful in and of themselves. Taking the time to access the information about the child in a critical situation at first glance may seem to actually create more of a stressful situation. So what ways could this added stress be reduced, and how could this program help practitioners get past the intimidation of treating patients with special needs?
Sure. And I've never, that's an interesting question, because I've never thought of it that way, looking at that and saying, oh my gosh, that kid looks terrifying, because a lot of them do. We have not received that feedback. All the feedback we've received from paramedics is that it was extremely helpful, and they were so glad they knew what they were walking into before walking into a house and being hit with it, being completely unprepared. That being said, those super scary kids, we definitely we don't just enter a plan into STARS and be done with that. We have we communicate with the EMS agencies. We always encourage them to meet the kids ahead of time. We always offer training with that, and we're here. We're here to field any questions that you may have. We will come out with you if we're able to do a home visit. And we've also customized quite a few virtual trainings with our kids, and those can live on our LMS system. It's something I wasn't able to add. I wasn't able to add every aspect of STARS, but within the database, there's a resources page that you can look at many of our lectures, and we can actually assign training to agencies so they can become a little bit more familiar than just looking at that plan. Now, if the child's traveling out of their area, and they happen to be in your district and you happen to be dispatched to them, then you might not have that. So I don't have an answer to that causing increased anxiety. I would hope it wouldn't. I would hope it'd be less than just being completely unprepared once you arrive. I don't have a fantastic answer for that. So that's all I have.
Thank you. Are the providers that interact with the patients you've shown in your presentation critical care paramedics, nurses, or what's their background? What's their practicing level?
Oh, of the photos that I show, that's everything from volunteer first responders to critical care paramedics, flight teams, nurses. We need in order for STARS to work. I have what I dub my chain of survival. Just like AHA has, everybody has to be involved. And we have plenty of kids who live in rural areas who do have volunteer first responders, and we get them as prepared as can be. They are actually sometimes some of the most responsive when it comes to wanting to know more about these kids and knowing everything they can do. Of course, it depends on weather and availability. Everything has to align, but we do have several children who have within their STARS plan includes dispatching a HEMS unit. So we've had several successful calls with that. With this call, if this kid, parents call 911, they're so rural that they immediately put our local area vac on standby, and they've been involved in the training too. So they've been able to get the patient directly to us, which has been nice.
Thank you.
Mm-hmm.
And can you talk about kind of the perimeter of the program? So is it local? Is it just in Missouri? Is it nationwide? Or kind of are you working with some of the surrounding states? Because as Evelyn mentioned, there's, being on the border, that there are kids in Illinois who utilize the STARS service.
Yeah, so currently STARS is, we've enrolled children all over, almost, I think we've almost hit every county except for maybe 3 or 4 in our northwest corner. But STARS was when we built our database, we intentionally built it to be robust enough to take on a national load if that would be possible. I have no desire to own this, a special needs program for the country, and I'm not competitive when it comes to STARS, but we do see benefit in having one program, especially when it comes to disaster and just the format of it. For it to serve more as a registry. I don't know if anybody is very familiar with working with the trauma registry, but I would love to have something like that so that we can, better track these children, their growth, what types of emergencies they have, and where they are truly getting into trouble. It would be nice to be able to have good metrics on that. If you look for publications regarding emergency care for these kids, it's going to be really hard to find anything that is definitive, that tells you how often they have difficulties and what types of difficulties they have in emergencies. So to answer before I go on and ramble too much about that, we at Cardinal Glennon, we truly believe that pediatric hospitals need to take ownership of this. We take suggestions from everywhere, from someone like EMSC or larger organizations, taking more of a leading role of it, but the pediatric hospitals themselves, by this design, need to be responsible for discharging, taking care of creating the plans for the high-risk children they're discharging. We say that you need to be, for lack of a better term, if you're creating them, you need to make sure you're protecting them beyond your 4 walls, and including EMS as an extension of the care team. So that's what I look at it as. Our community hospitals, our EMS, they are an extension of our care team for our most fragile children. Our plans are also updated continuously. So if I don't touch a plan in 6 months, we get a flag. So we have to go back and update it. And that comes from the hospital as well. So we always have the most up-to-date information on this kid. there isn't never a fee for viewership for STARS, but for pediatric hospitals to join, we have a very small fee that does nothing but help with maintain the database itself and the tech side of it. So it's a subscription fee for pediatric hospitals to have it, but they essentially would have their own access to STARS and can build out their own program with their surrounding EMS agencies and hospitals.
And you mentioned that you do a whole lot of trainings and do a lot of education. So where could paramedics interested in having this kind of training related to STARS go to get it?
My email is up here. If you were to email me, we'll give you, we can connect you with our LMS, and our plans, we just started it up a couple months ago, but our plans are to get that up and running with dumping all of our trainings into that. So we did go for CAPC accreditation, which is amazing, but it does take us a little bit longer to get them uploaded in there to meet all of their standards. But we have an LMS that can be accessed for free too. You don't have to be a STARS member to get in our LMS.
And can you talk a little bit about how difficult it is to attract or kind of get pediatric hospitals to use this program, or what kind of carrots you do to get them in? So for example, Chicago has a large critical needs pediatric patient population, and it would be amazing for the medics to know when they're going in to respond to those calls.
Yeah. I can always buy in any of the clinical staff, so all the way up to the CMOs. Like, absolutely, we want it. The carrots are few, and that I could talk about for a full hour as far as payer models go. Everybody's like, well, you used to go to the payers, you have to do this. It's obvious that you save money here and save money there. I actually have another presentation just on that, on pitching to administration where you can save. So cost savings, you're not going to prove. It's other than, we say it's the right thing to do. Unfortunately, this population has not been impacted by CMS rules for readmissions. So pediatric hospitals are not penalized as far as payment goes for readmissions. When these patients keep coming back to you over and over, you're paid, but it's volume. And they don't see true cost savings in programs like STARS. Where it can benefit pediatric hospitals is being used as a proxy program to augment different certifications. And for example, at Cardinal, Glennon, our NICU uses it for their level 4 status. Our trauma team uses it for their level 1 program. It's just everything for outreach. So they can use that as an adjunct program when they're going for these verifications for site reviews. The new, Joint Commission, their new standards include more outreach and disaster planning. So there are many areas that it can be plugged in and used for that, also PR. But as I said, it's difficult to sometimes get these pediatric hospitals to buy in. Not going to lie about that.
Is the STARS program still accessible for patients once they are no longer able to be categorized as a pediatric patient?
That's a difficult one too. My medical director, he says he's willing to keep them as long as they're being followed by a pediatric subspecialty. 21 is when they're supposed to age out. It would be fantastic to have an adult program as well. I've never aged out, graduated a patient purely for aging out. If they still need us, I've kept them in. That would have to be up to the pediatric hospital, another pediatric hospital that would do this, if they wanted to truly, graduate for aging out or not. But we've continued to follow our children past the age. All I require is that their parents have documentation that they either sign their own HIPAA form or parents provide documentation that they are their POAs to sign that HIPAA.
And now we're going to have a couple questions more specific on the program, and then I'm going to do one that kind of encompasses what a lot of the
Sure.
questions are asking. So if a trach needs to be changed, will a trach size correlate similar to an ET tube?
Yes, it's the exact same. So if they have like a 4.0 ET tube, it'll correlate to a 4.0 trach tube. no matter what the brand, whether it be, Bavona, Shiley, million out there, it will correlate to the same size of the trach. It's all standardized ET tube. It's all standardized sizing.
And can the plan for the child be printed prior to them traveling?
Yes.
And then kind of encompassing some of the other questions about, I know we, all the managers talked a little bit about what's going on in the States, but for anybody on here, including RS managers, what would you say would be kind of the next step, or what would be a good first step if a state or an EMS agency wants to get involved and wants to start going about bringing stars to their state?
I would say reach out. I think you've already mentioned to reach out through your EMSC reps, but you got to hit those pediatric hospitals. And that's what we're here for. My team is here to help you do that. We can provide presentations for them and share what you dubbed those carrots. I call them the carrots too, or the shinies, for what benefit it can bring to them. And there's also potential for future benefit too as CMS rules change. But we are more than happy to help pitch to pediatric hospitals with you. Parents can play a role as well. I have a parent recently who found out that one of our other hospitals in our state that's not a standalone but does have an intensivist and critical care unit. She found out her hospital wasn't actively participating in STARS and blew up. So she's, having parents advocate to, like, why aren't we doing this? We need to be doing this. My child needs this. That's helpful as well.
Great. We have reached the end of all of our questions in there, and I don't believe we have any further ones in the chat. So if nobody else has anything, that will conclude this presentation.
Awesome. Thank you, everybody. Appreciate your time.
Thank you so much for this great presentation.